Hello, everyone. Welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist, trained at Duke University, been practicing in South Florida for over 22 years. I am the APD for Infectious Disease Fellowship here, and I am also a faculty for internal medicine residents. I chair the antibiotic stewardship for the four Broward hospitals, and I am also the infection control medical director. Zooming through ID is a focused learning session where the residents and fellows take ownership of their learning. When they rotate with me, when they do the infectious disease rotation, we either assign a topic of their interest. Either they pick a topic or we will assign a topic and they will do deep dive and then do research into that topic. And this is a session where they get to showcase and teach us what they have learned. Today, the presenter is Sebastian. Sebastian was did the infectious disease rotation with me and had a great enthusiasm to learn and was very professional and learned a lot of infectious disease. He saw a lot of infectious disease cases. Um, the topic is very interesting topic, so I will let Sebastian take over from now. Okay, go ahead.
Thank you, Dr. Gopal. I'm Dr. Sebastian Arango. I'm a PGY1 resident at Broward Health North Internal Medicine Residency. I went to school at Nova Southeastern University in Fort Lauderdale, and I had the pleasure of learning from Dr. Gopal about infectious diseases and how we manage these type of patients responsibly. Um, Today, I'm presenting a topic about HIV. I love HIV. I'm more passionate about immunology as a whole, but HIV goes very hand in hand with our immune system and our immune function. So this topic is really relevant for, that particular body system that I truly enjoy learning and talking about. So I look forward to presenting the material.
Great.
So is it okay if I share the screen now?
Yeah.
Okay, so like I mentioned, I'm going to be talking about HIV and how we prevent and treat opportunistic infections associated with it. This is based on the NIH and IDSA and HIV-MA guidelines of 2025. The purpose of these guidelines were meant to show and how we prevent exposure to opportunistic infections, how we protect our patients. When do we discontinue primary prophylaxis after the immune system has strengthened, how we treat the active disease while the patients are immunosuppressed. When do we start antiretroviral therapy and how we monitor the signs of its toxicity and how we monitor any other acute opportunistic infection that may arise, and how we can also prevent the disease from reoccurring, which is termed secondary prophylaxis, and at what point we typically tend to discontinue secondary prophylaxis. So how I have this presentation structured is I'll talk about specific microbes or generalized infections in the body. Um, so HIV patients are predisposed to developing bacterial enteric infections, and it's common when CD4 levels drop below 200. Salmonella, Shigella, and Campylobacter are common. We don't routinely cover prophylactically bacterial enteric infections, and we mainly avoid it also in travelers. In rare cases, we use rifamycin or azithromycin, which can be offered, and also immunizations are also recommended. In the cases that we need to treat empirically with CD4 counts of 200 to 500, and we have, severe symptoms of diarrhea that are enough to compromise function, We typically empirically treat outpatiently with azithromycin for 5 days or ciprofloxacin. If we're in the inpatient setting and the patient's more critical, we use ceftriaxone. And if we have any suspicion of Campylobacter or Shigella bacteremia, we have to use carbapenem for empiric therapy. So it's not that we start with carbapenem, but if we have those two in the differential, we would want to, reside with the carbapenem. Um, there's a lot of overlap, but for the specific organisms like Salmonella, ceftriaxone works effectively, and ciprofloxacin can also work PO. For Shigella, like I mentioned, we use carbapenem, but also ciprofloxacin is also an option. And for Campylobacter, we have azithromycin and ciprofloxacin as well. Commonly, we also have C. diff infections. The preferred is fidaxomicin, but we also very commonly use oral vancomycin. We like to avoid anti-motility agents as this is an inflammatory diarrhea. And then we also can treat recurrent C. diff infections. We use fidaxomicin over vancomycin if it's recurrent, which is typically preferred. And with patients with CD4 counts of over 200, we can do fecal microbiota therapy, which can be considered after 3 episodes of C. diff. And next to the text is the recommendation strength. So AI is recommending that it's strong strength of evidence, and C is to suggest that it's less evidence-based. With people with recurrent CDI, we, like I mentioned, use fidaxomicin. With people with highly elevated blood white cell count, we define severe as with high leukocytosis of greater than 15,000 or serum creatinine over 1.5, with non-severe being less than those numbers. Bartonella is a species that is most commonly known for cat scratch disease, but it can cause something called trench fever, and it can be a persistent bug in terms of causing relapsing bacteremia and also a cause of culture negative endocarditis as well as bacillary angiomatosis. People with severely immunocompromised states of CD4 less than 50. We do not do primary prophylaxis for Bartonella. It's not generally recommended. The treatment of Bartonella includes doxycycline as well, but depending on the severity and the symptoms and where the symptoms are residing, that can also guide our treatment. For CNS infections and nervous system infections, we still use doxycycline, but we can add or take away rifampin. For endocarditis, we use doxycycline, but we always do include rifampin as well. Um, and all of these have varying lengths depending on how long and where the infection is located. That also guides the length of treatment for the patient as well. For severe decompensated disease, again, doxycycline, and we use rifampin as well. Bartonella is a disease that can cause quite persistent relapsing. And so there are different regimens that can be used. If your first regimen of doxycycline didn't work, you can transition to another agent like erythromycin. And then again, you treat for the specific time period and see if that medical therapy worked better than the previous one. For long-term suppressive therapy, if relapsing is persistent after greater than 3 months, we continue to treat with macrolides or doxycycline as long as the CD4 count is less than 200. And then we consider discontinuing long-term therapy after 3 to 4 months, and once the CD4 count has rise over 200 for at least 6 months. Um, and then we can also use tighter levels to help guide our treatment. And some specialists would also recommend that the Bartonella titers be decreased by fourfold before being comfortable with discontinuing long-term therapy. Some of the complications are IRIS, which is immune reconstitution syndrome, is associated with Bartonella treatment. And so with patients that are naive to ART, they can take it at the same time, but patients with CNS or ophthalmic lesions should be treated with doxycycline and rifamycin for 2 to 4 weeks before instituting ART. So depending on where these infections reside can also dictate when we initiate antiretroviral therapy. A very common organism is Candida. We do not routinely primarily prophylact for Candida because the disease is very associated with low risk and mortality. Um, like I mentioned, there's no antifungal recommended, and not even secondary prophylaxis is indicated. Um, our preferred therapies for candidiasis is fluconazole, initially given with a loading dose, then followed up with a maintenance dose. There's alternative therapies as well, depending on where the location of the infection is located as well. If these treatments fail, there's posaconazole, which works well, and then amphotericin B, but these are all agents used after the failure of fluconazole. For chronic suppressive therapy, this is usually only indicated when there is recurrent oropharyngeal or vulval candidiasis. Um, and it has to be very severe and frequent reoccurrence. For oropharyngeal, like I said, we can use fluconazole. For esophageal, fluconazole or posaconazole. And for vulval vaginal, fluconazole also works. We discontinue secondary prophylaxis once the CD4 count has increased past 200. Chagas disease is tripasomal cruzi. It's associated with the kissing bug, and it's associated with Chagas disease commonly found in tropical countries in Brazil. Um, some guidelines recommend that all patients with HIV with the epidemiological risk factors of Chagas should be tested for antibodies to tripasomal cruzi to detect any latent infection. To prevent the manifestation of disease, some patients receive a single course of benzodiazole or nifroximox, recommended by some experts as well, with the therapies for acute and reactivated being similar as well. Treatment is not recommended for patients with advanced Chagas cardiomyopathy, which is a complication of advanced disease as well. There's coccidioides mycosis. This is a very common soil-dwelling fungus that is ubiquitous in our environment, obviously very associated with endemic countries, endemic areas such as the San Joaquin Valley, California, Arizona, Utah, Nevada. They can cause focal pneumonias, diffuse pneumonias. They can have extrathoracic involvement, meningitis. The primary prophylaxis or preventive therapy is not recommended for patients with HIV, regardless of CD4 count. But those with moderate to mild pulmonary infections, fluconazole or itraconazole can be used. For severe pulmonary or extrapulmonary disease, not including meningitis, you can use amphotericin. And then for meningeal infections, the preferred agents is fluconazole, and then alternatives, ultraconazole or voriconazole as well, with obviously expert consultation. Relapsing is reported with patients after taking triazoles. Suppressive therapy should be lifelong, and discontinuation is not recommended once these infections are present. In general, delaying ART while treating coccidioides mycosis is not necessary. However, in highly immunosuppressed patients with CD4 counts less than 100 with disseminated disease, clinical decline may occur with the initiation of ART. Community-acquired pneumonia, patients with HIV typically are higher rates of developing pneumonia. There's obviously preventative measures such as our vaccinations that can be used. Um, Many of the treatments guide that patients with HIV and non-severe CAP should be using the same medications as patients with not HIV, which can be either beta-lactams, macrolides, or respiratory fluoroquinolones. With patients with severe pneumonia, we use IV beta-lactams plus either azithromycin or respiratory fluoroquinolones such as moxifloxacin or levofloxacin. Cryptococcus, which is very common in severe infection with HIV patients. It's caused by Cryptococcus neoformans. Um, it's present worldwide, very severe illness with subacute meningitis or meningoencephalitis with fevers, typically are their presentation. This therapy includes an induction therapy, which is amphotericin, typically given for 2 weeks. Then a consolidation therapy. We usually use a LP after 1 or 2 weeks of induction therapy to document that cultures are negative in the CSF. And then patients also use maintenance therapy of fluconazole for up to greater than a year after the initiation of antifungal therapy. For the criteria for stopping maintenance therapy, at least 1 year of initiation from antifungal therapy, and the patient remains asymptomatic with a CD4 count greater than 100, and RNA that is being responsive to antiretroviral therapy. If CD4 count does decline back down to 100, it is recommended to restart maintenance therapy. It is estimated that about 30% to 10% who have cryptococcal meningitis experience iris as well after the initiation or reinstitution of ART. Um, it can occur, but it's advised to continue both ART and antiretro ART and antifungal therapy. Is still recommended to be continued at these cases. We have cryptosporidosis as well, which is caused by cryptosporidium, which infects the small bowel, can cause infectious diarrhea, and those that are immunosuppressed. For these patients, symptomatic management, including aggressive oral and IV hydration, and then symptomatic treatment of diarrhea with anti-motility agents as well. For these patients, the tincture of opium seems to be very effective for them as well. Patients with HIV not taking ART should initiate ART to achieve restoration of their CD4 count to greater than 100, with other supportive measures if this isn't able to happen as well. CMV is cytomegalovirus as well, but used to maintain CD4 count greater than 100. Primary prophylaxis is not recommended for CMV as well. And then monitoring is generally not recommended. So for the treatment, again, this is dependent on the location of the infection. The preferred therapy for retinitis, colitis, or esophagitis is valganciclovir or ganciclovir. For pneumonia, ganciclovir is preferred. And for neurological manifestations, ganciclovir plus foscarnet can be also used as well. Systemic anti-CMV therapy for at least 3 months is generally recommended to increase the CD4 count greater than 100 while on ART and ensuring that the retinitis are remaining suppressed and not reactivating. So for hepatitis B, a common infection as well, people should may get vaccinated for hepatitis B, which is a general recommendation as well. All people with HIV and hepatitis B co-infections, regardless of CD4 or hepatitis B levels, should be treated with ART. That includes drugs that are both active against HIV and hepatitis B. For art therapy, which is effective against hepatitis B, tenofovir alafenamide is recommended, plus etracidobin as well, or TAF, which can be used with the addition of lamivudine as well. Tenofovir Disoproxil fumarate is also an agent also used as well. The abbreviations are here for TAF plus tenofovir. In patients with chronic hepatitis B infection, anti-hepatitis B therapy must be given if there is a switch to nucleoside sparing regimen. Switching to a one pill regimen of I'm sorry, I'm sorry, one second. Sorry. So for hepatitis B, those with those infection, you want to keep a simple medication regimen. The treatment for hepatitis B with HIV can be complicated and should be guided with infectious disease when making the decision, as resistance can be born and reactivation of hepatitis can occur with inflammation to the liver as well. These are often called hepatitis flares. For hepatitis C, these are also very highly nuanced treatment regimens. They're simplified algorithms and they're more complex depending on genotyping um, and depending on the level of their disease, if there's cirrhosis present or not. Um, there are many antiretrovirals as well present. And as this is more nuanced, I'm not going to go too much on the details so I can continue the presentation, but the information is available. Herpes, very common as well. Primary prevention of herpes isn't generally recommended. Um, we typically use valacyclovir, famciclovir, or acyclovir. For more severe mucocutaneous or visceral disseminated HSV, we can use IV acyclovir as well. For ophthalmic manifestation, valcyclovir, acyclovir, and ganciclovir drops can be used and oral medication as well. Um, for HSV meningitis, we typically start with acyclovir IV and then can switch to valcyclovir PO once there's clinical improvement. And for encephalitis, we continue with acyclovir IV. We have histoplasmosis, a very common fungal infection as well. This is more associated with Central and South Central United States, Ohio, Mississippi. For histoplasmosis, the indication for initiating primary prophylaxis is those with less than a CD4 count of less than 150. Preferred therapy is itraconazole, and to discontinue the primary prophylaxis, we want to ensure that the patient is on a good regimen of antiretroviral therapies. They have a CD4 count of greater than 150 for 6 months, and that their viral load is undetectable. For mild to moderate disease, itraconazole orally can be used. For meningitis, we can use liposomal amphotericin for an induction period. And then for maintenance, itraconazole if greater than 12 months, as well as resolution of CSF findings. For long-term suppressive therapy, this is indicated for severe disease or central nervous infection after the therapy has been completed for greater than 12 months. And there's a relapse despite appropriate initial therapy, with preferred therapy being itraconazole. For Mycobacterium avium, primary prophylaxis isn't generally recommended for these patients. CD4 count, it's associated with CD4 count less than 50 and not receiving ART. They can take azithromycin or clarithromycin. For treating disseminated MAC disease, the preferred therapy is at least 12 months with at least two drugs as initial therapy to prevent resistance. We typically can use chlorpromazine plus ethambutol or azithromycin plus ethambutol. For chronic secondary prophylaxis, it's the same regimen. If ART does not result in immune reconstitution, people with HIV and disseminated MAC should be continued with long chronic maintenance therapy. For discontinuing chronic maintenance therapy or secondary prophylaxis, we want to complete at least 12 months of therapy with no signs of MAC disease and have sustained a CD4 count greater than 100. And then the indication for restarting chronic maintenance therapy is if the patient is consistently showing up with a CD4 count back less than 100, or, our medication isn't possible. For Mycobacterium tuberculosis, this can occur at any CD4 count. The recommendations for treating latent TB to prevent TB disease in people with HIV, as they are at higher risk of developing active T tuberculosis. The indications are positive tests of screening for latent TB. People with immunosuppressions may have smaller skin testing measurements, and so the criteria for that changes if someone is immunosuppressed. Um, the preferred therapy is ionizide as well as rifampicin plus pyridoxine, and there's caution with rifampin as protease inhibitors and integrase inhibitors have dose adjustments that may be required as well. For TB, the intensive phase includes for 8 weeks ionizide plus rifampin or rifabutin plus uh, pyrazimide plus ethambutol with peroxidine. And then the continuation phase for the TB that is susceptible is ionizide plus pyridoxine and the addition of rifampin or rifabutin as well. Some patients are at high risk for paradoxical TB iris. Patients that are starting ART within 30 days after TB initiation and those that have a CD4 less than 100, who are responding well to TB therapy and do not have rifampin resistance, Kaposi sarcoma, or active TB, can be placed on prednisone to help the inflammation. PCP is a very common ubiquitous organism as well, presenting with dyspnea, fever, cough, and chest pain, usually present with patients with CD4 counts less than 200. The indications for initiating primary prophylaxis is a CD4 count of less than 200. If HIV RNA is above detected limits and CD4 count less than 100, regardless of the RNA load. Preferred therapy is Bactrim, double strength. The indication for discontinuing primary prophylaxis is once the CD4 count increases from 200 greater than 200 for greater than 3 months in response to R. And you can consider it with patients within the 100 to 200 CD4 count if the RNA load is low for greater than 3 to 6 months. The indication for restarting primary prophylaxis is CD4 count less than 100. And we usually start ART once the CD4 count is within 2 weeks and greater than 50. Indication for secondary prophylaxis is prior infection with PCP. Again, therapy is similar with Bactrim. Alternative therapy can be used with Dapsone as well, with primethamine plus leucorvine as well. And then the indication for discontinuing secondary prophylaxis is CD4 count increasing from less than 200 to greater than 200, and then a virally suppressed load. PML and JC virus, this manifests as neurological deficits, usually insidious. Um, Usually art is the treatment for this and continuation of art. Syphilis is a common disease also. Primary syphilis can be present in the genital area or the musculocutaneous lesions as well. Some people can develop tertiary syphilis with gamma and then cardiovascular syphilis as well, or late neurosyphilis can develop if the infection is persistent for many years untreated. Preventing the disease, anyone with some exposure within greater than 90 days should be tested. For primary, secondary, and early slash latent syphilis, um, or early latent syphilis, the recommendation is benzathine penicillin given intramuscularly in one dose, or alternatively, if the patient is penicillin allergic, they can be put on doxycycline for 2 weeks. Late latent, which is greater than a year, recommended therapy is penicillin IM for 3 doses, with the alternative being doxycycline for 28 days. For neurosyphilis, otic or ocular syphilis, the recommended therapy is aqueous crystalline penicillin, um, given daily, administered every 4 hours for up to 14 days. Toxoplasmosis is very common in undercooked meat and the food and as well as cat feces. Indication for preventing primary prophylaxis is a patient who has a Ig positive with a CD4 count less than 100, with the preferred regimen being Bactrim. Indication for discontinuing primary prophylaxis is once the immune system has restored its CD4 count and has sustained that CD4 count for greater than 3 months, and we reinitiate it once the CD4 count drops again. Preferred agents are primethamine, which is based on weight as well, and for patients less than 60 kilos, they can use sulfadiazine and leucorrhine. Bactrim is also an option as well, twice daily for at least 6 weeks. For chronic maintenance therapy, preferred agents are primethamine as well, with sulfadiazine. Bactrim is also used, as mentioned, for discontinuing the therapy. You can discontinue it after you've completed the initial therapy with signs of improvement or the patient becoming asymptomatic and their CD4 count rising above 200 for greater than 6 months, and then restarting it after the CD4 count drops below 200. Varicella, um, many again recommend vaccination. Long-term prophylaxis with BZV medication is not indicated. Um, Preventing herpes shingles is based on vaccination as well. For those that have been exposed, Varizig can be used as soon as identified within 10 days after exposure. If post-exposure, Varizig can be administered. You can wait greater than 5 months before varicella vaccination. For treating varicella infections or chickenpox, we can use valcyclovir, famciclovir, and for severe cases, acyclovir IV. For shingles, we can use valcyclovir, famciclovir orally, and this can be up to 7 to 10 days depending on symptomatology. For ophtho for herpes zoster ophthalmalitis, acyclovir IV is used until clinical improvement is evident, and then you can switch to oral therapy of valcyclovir, famciclovir. So these guidelines obviously are very extensive, and there are a few organisms that I didn't get to discuss. These are the ones that have been not mentioned in this presentation, but I'll gladly be able to create something new and be able to present on these remaining organisms. And here are the reference that I used to provide the information in this presentation.
Okay. Yeah, hi. It was excellent presentation. Um, so the most of the things that you did a very great job. We will be seeing a lot of cases, like PJP during your wards. You will see them. Crypto we used to see a lot, but we don't see them that much. Crypto. The one point that I want to mention, reiterate, is if patient is having both HIV and hepatitis B, we need to make sure that we are treating both when we do the heart regimen. The Dovato is a medication that is generally not recommended, the two-drug regimen. So 10-hour based regimen is the one that is recommended for those cases. Uh, the We don't see a whole lot of crypto meningitis these days, but if you get a case, the management becomes very important because crypto meningitis can cause deafness and blindness, and it can be devastating. Candidiasis, you will definitely see. PJP usually may present as a pneumonia, but then sometimes the patient may not be diagnosed with HIV, so you will have to diagnose that. So very thorough, concise, and excellent presentation. Okay, good job.
Thank you, Dr. Gopal.